Assalamu alaikum, this is Dr. Hasna, and today we will discuss the various ligaments and joints of the scapula along with a little clinical anatomy. Let's give it a recall that we had the subscapularis muscle in the costal surface, the serratus anterior in the medial border of the costal surface. We had the supraspinatus in the dorsal surface. On the supraspinous fossa, we had the infraspinatus originating from the infraspinous fossa. On the dorsal aspect medial border, there was the levator scapulae, the rhomboid minor, the rhomboid major muscle. The latissimus dorsi was on the inferior angle of the scapula. On the lateral border, we learned that there was teres minor muscle on the upper 2/3 of the lateral border and a teres major muscle originating from the lower 1/3. Moving on, we talked about the crest of the spine having an upper lip and a lower lip. Lower lip, there was the origination of the deltoid all the way to the lateral border of the acromion, while insertion on the upper lip was the trapezius muscle, which extended its insertion into the medial border of the acromion. And then we talked about the muscles of the arm. From the supraglenoid tubercle came the long head of bicep. Tip of the coracoid process gave origin to the short head of the biceps brachii and the coracobrachialis. The infraglenoid tubercle gave origin to the long head of triceps brachii. The two smaller muscles were the supraclavicular notch, just medial to it was the inferior belly of omohyoid, and finally the superior surface of the coracoid process contained the insertion of pectoralis minor muscle. So now let's start with the ligaments attached on the scapula. Let's talk about the ligament that you already know about, the coracoclavicular ligament. The coracoclavicular ligament basically is attached to the coracoid process in its conoid and trapezoid parts. And then it goes to the clavicle and forms a connection between them. Moreover, there is a ligament called the Coracohumeral ligament. The name says it that it binds the coracoid process to the humerus. This ligament is attached close to the root of the coracoid process. There is a ligament called the Coracoacromial ligament. Now this binds the two acromion process and the coracoid process. This ligament begins from the lateral border of the coracoid process all the way to the acromion tip. And then we have the two important ligaments that convert two notches into foramens. So first I talked about the Spinoglinoid Notch, and then I talked about the suprascapular notch. Let's firstly talk about the Spinoglinoid Notch. This bears a ligament called the Spinoglinoid ligament, which bridges this gap and forms a foramen. A foramen is also known as a hole. So the hole is formed for a reason, and the reason being that it accommodates the passage of the suprascapular vessels and nerves. So the suprascapular vessels and nerves pass right beneath or right inside through the foramen. Moving on, we have the suprascapular notch. This is bridged by a ligament called the transverse ligament that converts the suprascapular notch into a foramen. Now, since the nerve and artery come through the spinoglinoid notch, they pass through the supraglinoid notch. However, this time the nerve goes below the transverse ligament while the suprascapular vessels pass from above the transverse ligament. Moreover, let's talk about the joints of the scapula. Scapula forms the most important shoulder joint, which connects the shoulder girdle to the humerus. Hence, the glenoid bears the glenoid labrum or the lip and the capsule of the shoulder joint. As you remember, there was a facet right on the medial border of the acromion. Now this forms the acromioclavicular joint, and the margin of this facet bears the capsule of the acromioclavicular joint. So these are the two joints of the scapula. Let's talk a little about the clinical anatomy of the scapula. What happens is when there is paralysis of the serratus anterior, recalling the serratus anterior was inserted into the medial border of the costal surface of the scapula. When there is paralysis of the serratus anterior muscle, the medial border, which was firstly pulled by this muscle, due to the paralysis is let loose, leading to the medial border being unduly prominent when you were looking at the back of the person. This is called winging of scapula. Since this muscle helped in performing the overhead abduction, now serratus anterior is paralyzed. Overhead abduction beyond 90 degrees cannot be performed by the limb. So this was the clinical anatomy of scapula. That was all for scapula. Thank you so much for watching, everyone. Tune in next time as I teach more bones. This is Dr. Hasna signing off.